I had a heart attack in 2012, and I didn't really recover very well. What had happened is I had a descending, what they call an aortic dissection. And they had looked at it and scanned it and said, we can't do anything to help you.
The aorta is essentially a pipe that originates at your heart, and it travels upwards towards your brain before it arches over, then travels down the left side of your chest. And the branches of the aorta supply all your vital organs throughout your body.
I lived like that for quite a few years, with that hanging over me, knowing that it could go at any time. But then what changed everything was I got an ascending dissection that went up into the arch, and I was blue lighted up to St. Thomas's. And when they saw me, they had a whole different take. They suddenly gave me hope that they could do something to help me.
The prognosis for Teresa when you present with an acute problem that affects the aorta close to the heart in the setting of somebody with a connective tissue disorder, which in her case is called Loeys-Dietz, is very bad. Without surgery, practically all of them will die within a certain time frame.
He said, if we don't do it, you will definitely die. We just don't know when. That was his words. So I said, well, I don't really have an option.
Surgery really was life-saving, and it really was necessary. Now, the magnitude of surgery of that kind is very high indeed.
Everything was rebuilt. And yeah, it was hard.
Following on from this major surgery and the fact that she recovered from it so well, we're left with the problem in the remainder of her aorta, which already previously had a tear in it, and it was already aneurysmal, and it had been increasing in size over time. I took her case to our multidisciplinary meeting.
We're a team of radiologists, interventional radiologists, cardiothoracic surgeons, vascular surgeons that sit down and discuss each of these cases, and we decide the next steps for their treatment. The decision as to whether or not to perform surgery was challenging on its own. We spent a lot of time as part of a multidisciplinary team with our medical colleagues deciding how she might be optimized and how she would react to the strain of even the minimally invasive surgery. I had long conversations with Teresa about the risk, including paraplegia, the risks to her heart, and the fact that she may not have survived surgery.
So I went in worried because there were still risks.
Teresa's procedure was done in 2 stages, a few weeks apart. She had the proximal stents placed first at the level of the belly button.
I have to say, out of everything I've had done, that was so easy. It was a piece of cake. But Professor Modarai said to me, that was the easy bit. The next bit won't be so easy.
And then she came back for the more intricate part of the procedure, which is known as her fenestrated repair. This used the custom-made stent graft.
Ready, fly.
The stent graft needs to go from healthy tissue back down to healthy tissue, and it seals at the proximal or the top end and seals at the bottom end.
Elephant trunk and sternum.
Okay. Now, Mike had been quite clever when he'd done his procedure in that he'd left what we call a frozen elephant trunk. So it's open surgery, but right at the end of his surgical repair is a stent graft that essentially hangs in the aorta for the next stage, which meant that I was able to pick that up and use a complex stent graft to extend the repair from high up in the chest down into Teresa's pelvis. So in effect, replacing her entire aorta with a combination of open surgery at the top and endovascular surgery for the rest of the route.
Take the overlay off now and open the cones.
So these are very complex cases, and much of the work is done outside of the operating theatre because they have to be planned very precisely. The stent grafts that we use are custom made by hand based on the imaging of that very patient.
Stents ready.
We again discussed the optimal design at multidisciplinary meeting. There are no unilateral decisions when it comes to these kind of treatments. It's a team effort, and it's the team that ensures optimal results. Part of the technology is the design of the stent graft to allow it to be of a size that can then be introduced and unsheathed. The other part of the technology is imaging.
Okay, X-rays are on.
Okay.
These procedures, as opposed to open repair where you can directly look at the aorta, these procedures are reliant on X-ray guided techniques that allow you to visualize the aorta and its branches and allow you to visualize the stent.
Up a bit.
So to have a system that is flexible enough in order to be able to image the entire aorta is very important. You need high quality X-ray guidance images. You need a flexible imaging system in order for you to be able to visualize the aorta and, crucially, place the stent in the right position. The operating theatre environment is where a highly functioning team is most important. And this team consists of anaesthetists who look after putting the patient to sleep and make sure that they're safe throughout the procedure. When it comes to the imaging, we have radiographer colleagues who make sure that what we can see is optimal throughout. We have the operative team that consists of 2 operators and an assistant, scrub nurses who are expert with the devices, because it's very important that we are given the right devices at the right time. It's a group of people working towards one aim, and it's crucial for the success of the procedure.
Keep there. Okay.
We have learnt how to design the best solutions for these patients. Intraoperatively, imaging has improved, so we can visualize the aorta much better, which means the procedures are quicker and they're done more smoothly. The actual stent grafts that we use have developed in that they're lower profile, the fabrics have improved. Our knowledge of what works and what doesn't work has also improved the way that we design the stent grafts and where we position the different components of the stent graft.
Okay, come RAO 65 and 10 of cranial on the celiac.
These are not always straightforward procedures, but I'm pleased to say that in Teresa's case, the operation was routine, and when we did the completion angiography on the operating table, it confirmed that the aorta was successfully realigned and the aneurysm was sealed.
They're absolutely marvelous at St. Thomas's. I have to say, I felt very supported. I felt really like I had a good team, and I trusted them. I really do. I still do. I think they're amazing people.
The risk of aortic rupture is now removed, so she can get on with her life normally and without having to worry about that anymore. So I'm very pleased with the outcome.
When I was first given a diagnosis that this is what I had, they had sort of gone back into my history. My father was struck down with heart problems. He died when I was 17, but it wasn't just him. My grandmother died when she was 40 from the same thing. And now my son has it and is waiting to have heart surgery, and he's 35. It's heartbreaking, but at the same time, I feel like he's got people there waiting that are going to help him.
Using data to inform our practice is key. Increasingly, we have developed links with colleagues around the world and are able to share our experience and share our data so that colleagues can benefit from our experience. In the past few years, collaboration between clinicians, between academics and industry is being encouraged more and more by institutions, by grant funding bodies, and I think that's the only way that we'll make conceptual advances. So the fact that we have this developed endovascular technology and increased expertise in treating increasingly complex pathologies means that we're sometimes performing long procedures, which increases the radiation exposure to both the patient and to the operator.
Can Norma stop the breathing, please?
We need to think about ways in which we can reduce and eventually do away with the radiation exposure that's associated with the procedures. And one example is fiber optic real shape technology that allows visualization of catheters and wires within the aorta without the need of X-ray exposure. The early indications are that it's very useful, and in the fullness of time, it will become more and more incorporated into the standard workflow of performing one of these procedures, I would hope.
Somebody said to me once, to plant a garden is to believe in tomorrow. And I really believe that. Every season, I put stuff in that's not going to come up until the next season, because then I'm going to be around to see that next season. I've said to both my surgeons that what they've done for me is miraculous. I'll get emotional now, is miraculous. And I said to Professor Modarai, you're like a magician to me. What you've done for me, I'll never be able to thank him enough.